Welcome everyone to our webinar titled Assessment of Safe Four-Wheeled Mobility Aid Use for People Living with Dementia. The Safe Use of Mobility Aid Checklist facilitated by the Fall Prevention Community of Practice. My name is Shamiza Allard and I am the Knowledge Coordinator at the Ontario Neurotrauma Foundation, also known as ONF. ONF sponsors the Fall Prevention Communities of Practice Loop and Loop Junior along with the annual Fall Prevention Month campaign. So before we begin, I'd like to give you a quick rundown of the Zoom meeting platform. Your screen may look a bit different depending on the type of computer that you're using, but if your screen or your Zoom application is opened in full screen, you can double click or press the Escape Full Screen button on your keyboard to exit full screen. There should also be a button on the top right corner of your screen that says Exit Full Screen. In this case, it says Enter Full Screen, but it depends on the view that you're in. The webinar technology consists of two parts, audio and visual. Both audio and visuals are provided through your computer monitor and speakers. To test or adjust your audio settings, look for the Audio Settings or Join Audio button in the bottom left corner of your screen. And this will provide options for testing your computer microphone and speakers. So if you look to the bottom center of your screen, you will see buttons that will allow you to access the chat box, raise hand, and Q&A features on Zoom. The chat box allows you to send messages to webinar presenters and other webinar participants. You can use the raise hand button if you want me to connect with you through the chat box. You can submit questions through the Q&A box. You'll only be able to view, just as an FYI, you'll only be able to view questions you have asked and not questions posed by other participants. So to simplify things a little bit, for technical questions, please use the chat box. And for topic-related questions, please use the Q&A box. And if you need to leave the webinar at any time, click the red Leave Meeting button at the bottom left right corner of your screen to do so. So if you have any questions about the technology at any time during the presentation, please type them into the chat box. My colleagues Cynthia and Helen will be monitoring this. Alternatively, you can email me at shamiza.allard@onf.org and I'll work with you to resolve any of the technical issues as soon as possible. So the webinar is being recorded and a YouTube link will be sent to all participants in about 1 week along with the presentation slides. So I would like to now introduce our presenter, Dr. Susan Hunter. Dr. Hunter is an associate professor in the School of Physical Therapy at the University of Western Ontario. Dr. Hunter's research interests are the rehabilitation of geriatric patients, particularly cognitively impaired older adults, and their experience of falls, frailty, and mobility decline. For a complete bio of Dr. Hunter, please view the Zoom webinar invitation. So without further ado, please take it away, Dr. Hunter. You may now share your screen.
Great. Thank you very much, Shamiza. I'm just opening up my screen here. And thank you everyone for attending and listening to the presentation. A few other things that I wanted to tell about myself because I think they help to inform this particular presentation. I am a physiotherapist, clinically by training, and I have been physio for 30 years. 20 of those years were in clinical practice, and then I went back to university to get a PhD in epidemiology and biostatistics. My clinical experience and practice in geriatrics and orthopedics has informed what my research questions and programs are. And this ties into this particular area of looking at falls risk in people who have dementia. I'd like to also let people know that this is a second in a series of webinars. About a month and a half ago, I gave the first webinar that was looking at mobility aids as fall risk in people with dementia. That seminar is available on Loop, as well as the slides from that presentation and a question and answer document. So for this particular presentation, the objectives are that at the end of the presentation, I would like you as the participants to be able to describe how we came up with the development and our evaluation of reliability and validity of the SUMAC, which is the Safe Use of Mobility Aid Checklist. And that is going through the components of this assessment scale that at the end you'll be able to apply the assessment scale to the evaluation of mobility aid use in people with dementia. So a bit of a recap from the first presentation I did, which was looking at mobility aids as fall risk in people with dementia. Overall, for people who have dementia, annual fall risk amongst these people is about 60 to 80% each year. People will fall at least once. And that is at least twice what it is for cognitively healthy community dwelling older adults. We really don't fully understand all the mechanisms for falls in people with dementia, but we do know that balance and gait problems are common and present early in the disease. And actually studies have found that changes in gait precede progression of dementia or cognitive changes that we can actually measure with all our testing tools. One of the problems for people with dementia is that if they do fall, they are more likely to sustain serious fall-related injuries than their cognitive healthy peers. In particular, this relates to hip fractures. Now, in the last presentation, I talked about why is it, or I'll first start by saying that mobility aids increase the risk of falls in people with dementia. Again, they increase risk rather than decrease risk. And in the previous presentation, I went through 9 potential explanations for why this would be the case. I'll go through them quickly as a refresher. One of the first possible explanations is that people are prescribed mobility aids or start to use them, and therefore, because they have problems with balance, leg strength, or gait problems. But even once we control for the reasons why people are prescribed and use mobility aids, they still have an increased risk for falling. We also know that the majority of people obtain mobility aids, whether it's a cane or a walker, without consultation with a healthcare professional. They'll either, family will acknowledge a need, or that it'll be a neighbor that's no longer using an aid, and they'll decide, well, why not, we'll try it. And the lack of access or consultation with healthcare professionals can have some downstream effects. And one of them is number 3, is unsafe maintenance of equipment. People aren't sure what needs to be done or even aware that annual maintenance of equipment is essential. The other thing about particularly 4-wheeled walkers is that if somebody does become unsteady or starts to lose their balance, the walker actually gets in their way of being able to make compensatory or recovery side steps because of the wheels of the walker. So it actually might get in their way of being able to correct their balance. Number 5 is rather interesting in that we know that the use of the walkers, it prevents the use of people's hands to effectively reach for support when there's a loss of balance. And it seems that all of us, regardless of age, even if we're young, healthy adults, that if we are holding on to something and we lose our balance, we are likely to continue to hold on to whatever we had in our hands rather than let go and reach for something else. So we don't have the luxury of being able to reach for that extra bit of support. Number 6 is an area that I've been focused on for the last probably 4 years, quite extensively with my research, in that use of mobility aids increases cognitive demands related to attentional processing and neuromotor control. So that using mobility aids is a cognitively demanding task. And it actually, for people who are newly learning to use mobility aids, they require a lot of brain work to be able to do use the aid. And even people who are experienced, have been using an aid for 6 or more months, still have to work quite hard to use the aid. There is a role for mobility aids. And again, the aid is prescribed because people have deficits in balance, strength, and gait. And one of the more recent studies we've done is that we looked at people who are currently using an aid, and we tested their gait when they weren't using their aid. And these people had demonstrable problems with balance and their gait. We then had them walk with their aid that they're normally using, and we found that their gait improved, their speed improved, and the stability of their walking improved. So those are good things. The third thing we did to these people is we then provided an additional distraction for them. We actually had them counting by ones. So these are people with dementia. We had them counting by ones, and their gait performance deteriorated. Their level of instability became consistent with that which was seen when they weren't using their aid. So we need to be aware that this is a potentially and brain-intensive activity for people, and that distractions in the environment, be it ambient noise, conversations, can actually end up deteriorating the benefits that people have for using their aids. Seventh reason is unsafe use of equipment. This could come from the fact, again, most people don't see a healthcare professional, or if they do, there's a limited number of visits that they have for training. Number 8 is healthcare professionals do not use methods that facilitate new learning in dementia. A lot of therapists feel uncomfortable or don't feel they have the expertise to be able to effectively work with people who have dementia, particularly where there's communication problems. And the last one is looking at timing of first using mobility aid. The later the mobility aid is provided or introduced in the disease process, then their ability to learn and master the task will be different than if it was earlier in the disease process, or if they had experience prior to the symptoms of their dementia presenting. So with that, the tool that I'm going to go over with you focuses on 2 areas, 2 of these 9, and that they're both potentially areas where there is intervention and we could make changes. So the first one is looking at physical function. So looking at balance, gait, and leg strength. And the second component is looking at safe use. So with this tool, the reason why it came about was I was looking to develop an intervention study for a gait training program and mobility aid program for people with dementia. And we're looking at how can we actually demonstrate our intervention has been successful. We can do gait features, but how do we know people are using the equipment more appropriately? Because anecdotally, we are aware that healthcare professionals say there are issues about safe use, that the aids are not necessarily being used in a safe way. And when we talk to clinicians about, well, how's the best way to proceed with this? We ask them, would they see a benefit of us developing a scale that would evaluate safety? And we found that yes, there was positive feedback because it would allow a standardized means of looking at safety. All healthcare professionals involved in someone's care would know explicitly what has been assessed and what components have been assessed. Within that, they are deemed safe. Again, all healthcare professionals would know where the areas of deficit exist, and that should help with development of interventions. And then it also provided a common language for healthcare professionals working with people who have dementia. So when we looked at developing the scale, the research team, which was made up with a kinesiologist, myself as a physical therapist and an occupational therapist, is that we reviewed existing mobility scales. We talked to experts in mobility among people with dementia, and we looked at healthcare textbooks that are used in teaching of healthcare professionals on what is taught about clinical skills for mobility aid training. We then had 3 focus groups of healthcare professionals experienced in care and rehabilitation for people with dementia, and that included geriatricians, geriatric neurospecialists, physical therapists, and occupational therapists. And in our discussions, it became very clear that 4-wheeled walkers were identified as the most commonly used mobility aid. That is why this assessment tool is based on the 4-wheeled walker. We see it across different settings as well, from the community all the way through to day programs, as well as long-term care settings. Our focus groups, not only were they different professionals, but they also provided care across different settings as well. Again, try to get that comprehensive view of input. And when we presented our focus groups, we asked, and we were looking for what were the minimal functional tasks needed to assess and evaluate independence and safety with a four-wheeled walker? And what were the components within each task that can be objectively evaluated for function and to represent safe use? And ideally something that could be used across disease severity spectrums. So at the end of our focus groups and our looking at existing knowledge, as well as our own clinical experience, we were able to come up with a tool that was comprised of 9 tasks and the components within each of these tasks that clinicians would observe for physical function and safe use. And the 9 tasks were the task of sit to stand, walk with a pivot to sit in a chair, walking on level surface, walking with horizontal head turns, walking with concurrent cognitive tasks, walking while negotiating obstacles, walking through an open doorway. The last 2 are the most complicated. Ask the person to open, walk through, and close a door that opens the way, and then to open, walk through, and close a door that opens towards. You will have a copy of the checklist. This is what the assessment scale looks like. This is the front page of it. And it includes all the test items. In terms of what is actually required in the execution of this assessment, time to complete the assessment is 10 to 15 minutes. The more you use it, the quicker you're able to go through it. It can be done by one person, but if you are worried about safety for the person who you are assessing, that you think they actually might be at risk for fall, then have a second person as a standby assist. For equipment, 3 pieces. You need a standard height chair with armrests, 2 cones or 2 obstacles that the person will be walking around or help to mark out distance, and a standard doorway with a door that does not self-close or have a self-closing mechanism. Space requirements is at most it is the 6-meter distance, because there's 2 path distances that you'll be having people walk on. One is a straight 6-meter path, and the other one is a 3-meter path, which we use in a figure of 8 setup. So from the SUMAC checklist, again, there are 2 areas that are assessed. First one is physical performance. Since we know the prescription of mobility aid is to compensate for deficits in strength, gait, and balance, we're looking to actually see, does the person's walking and mobility while they use the aid compensate, or are there ongoing deficits that are observable? The interaction with equipment is what we have termed whether the person engages with the aid in a safe manner. And at the end, there are 2 scores that come from SUMAC. There's one for physical performance and one for interactions with equipment, which indicates safety. So this is an example of what each of the task assessment looks like. The task is written up at the top. The task procedure is written, the equipment that's required from it. There's the 2 sections of physical function, interaction with equipment, and then the test items that you're actually looking for. Scoring is presented as how you actually add information up. And then at the end for each task, you can put in what the score is for physical function, as well as the interaction with equipment. In both of these, higher scores represent better function. Now, we have looked at evaluation of the tool that we generated through our healthcare specialists, and we looked at reliability. So we looked at how reliable is administering the tool within a particular individual, as well as assessments over time, and assessments between people. And that the evaluations were using therapists who evaluated people with mild to moderate dementia, performing each of the 9 tasks within the scale. And for the reliability between individuals evaluating the same person, what we have is called an ICC, which we found, we did it at 2 time points we evaluated, and the measures are 0.092 and 0.82. Scores range from either 0 or 1. The higher the score, the better the reliability. Scores in excess of 0.7 indicate clinical utility. When we look at performance of a single individual performing the test on the same person over time, again, we see very high scores that indicate high clinical utility. The other thing we wanted to be able to use this tool for is be able to evaluate change over time. Is that usually people use their mobility, they start with the aid at one point in time and they will continue to use it. But we want to be able to say, has performance changed? And this is where the minimal detectable change score comes in. So for physical function scores, we need to see a change in excess of 4 or 4 or more. And for change in the safety score, we need to see differences in scores in excess of 5. And this study that we did on the performance of the tool is under review for a journal. Now, when we looked at validity, we compared our test scores to already established tests, which is the TNEDI, or the Performance-Oriented Mobility Assessment, very common tool for assessing gait and balance in across care settings. And we found that the physical function score positively correlated to scores on the TNEDI test, such that high scores of physical function on the SUMAC were related to better function on the TNEDI test. And that's what we would hope to have found. We also looked at how our interaction with equipment score, did it relate to the TNEDI test, and does it relate to the physical function score? So are we testing the same thing twice, or are we looking at different things? And we found that our safety score, or interaction with equipment, is not correlated with physical performance, either through the TNEDI test or through the SUMAC's physical function score. So we are looking at two different domains in a sense, physical function as well as safety. So again, some practical points for using the tool. It takes about 10 to 15 minutes to complete. It is important that you feel comfortable with the items to look for in the assessment, because we all come with kind of our own internal gestalt of what we think we include in the safety assessment, but because we have standardized it, it may be different to what people's own assessment criteria might have been. So make sure you are aware of what you're looking for, because it will make the assessment easier. Again, consider having a second person if there's a high risk for falls. Again, there are 9 tasks. Tasks 1 to 3 are considered core elements. That's to sit, to stand, turn and sit in a chair, and walking on a level surface. They are fundamental, and that they can be performed for people across the entire disease severity spectrum. For task 3, there is a safety kind of requirement for proceeding to task 4 through 9, and that if a participant needs more than minimal assistance to walk, or cannot walk at least 5 meters, which are deemed as 0 function scores, then all testing is stopped and you don't proceed beyond test 3. Queuing is considered within the safety part, and we reverse scored that. So that if queuing is required for the person to be able to actually execute the task, then they score 0. Versus if you provide the person with the instruction and then they're able to do the entire task appropriately, they would get a 1 because they could follow all the instructions. If queuing is required, then that does relate to safety and whether the person would be able to actually execute a task independently without having somebody there to tell them how to perform the tasks safely. So this is the first task, task 1. Task 1 and 2 are combined. And for the testing procedures, we have people start in a seated position with a standard height chair with armrests. On the command go, we ask them to stand and then walk forward on a level surface for about 6 meters at their own selected pace, turn around, walk back to the chair and sit down. So the first part of that task is how well do they do for sit to stand. And in their physical functioning, the scores range from 0 to 2. And the things that we're looking at is in terms of on that first attempt for sit to stand, are they able to do it independently without use of arms, some help, or are they unable to do it? We then look at how many times it requires a person to actually go from sitting to standing. If they only require 1 attempt, then they have full scores. If they need assistance, then they get 0. And then we look at what their balance is upon standing. If they're steady with arm support, they have full scores. If they need to use their arms to chain balance, 1 point. And if they're unsteady, then they get 0. In terms of interaction with equipment, in all of the tasks, we're looking at is the behavior present or not, rather than gradations of it. Behavior is absent, it's a 0. If the behavior is present, it's a 1. And again, the interaction is looking what are behaviors that indicate safety rather than what doesn't indicate safety. There's too many possibilities there. So in terms of interaction with equipment, again, so is the walker positioned in front of the person within arm's reach? So how do they set themselves up? Are the brakes engaged on the walker? Do they reach 1 hand at a time to grasp the handle of the walker as they stand? Do their feet remain within the base of support of the walker? And then once they're standing, do they have a nice upright posture versus are they leaning forward over the gait aid? And do they establish balance before they unlock the walker? And again, do we need to cue them? If we have to cue them, then they get 0 if cueing is required, and no if it's only 1 point. And again, so just demonstration of sit to stand and what it should look like. Once they get standing, we then have them walk forward, and we look at what happens when they come back to sit in the chair again. And with this, in terms of physical function, the tasks of relevance that were identified is that when they're walking, they turn so they are properly aligned with the chair to sit down. So are they able to do that independently, steady with no loss of balance, and they take continuous steps to achieve it? Or do they turn slowly, several small steps to catch balance following the turn? Or are they unable to do it or fail to properly align themselves? It looks like they're going to miss sitting on the chair. Or is the person able to walk backwards so that they can actually feel the chair behind their legs? Again, full marks go to are they independent and they're steady, there's no loss of balance, and it's continuous steps. Part marks go for they're able to do it, but they're slow. It's not a freely executed series of steps. And 0 is if they're unable to do it without physical assistance, or they don't walk backwards. They're actually too far ahead of the chair. And then we look at actually how they're able to lower themselves into the chair. If they have smooth control lowering into the chair without use of arms, then they get full marks. If they use their arms or it's not quite a smooth motion, then there's part marks. But if they misjudge the distance or body alignment, or they just plop into the chair, then that is indicative of lower extremity muscle weakness. Then we're looking at giving them 0 scores. In terms of interaction with equipment, we're looking at, again, does a person's feet remain within the base of support for the whole execution of the task? Do they maintain their hands on the hand grips of the walker during the turn? Do they maintain an upright posture versus do they start to semi-sit while they're making the turn versus waiting until they're actually all the way back into the chair? That their feet do not collide with the walker as they execute the turn, that they engage the brakes on the walker prior to sitting, and that they reach 1 hand at a time to grasp the chair as they sit down. Again, cueing, if you need to ensure that the person actually executes appropriate tasks, then the cueing, they get 0 marks because you had to provide the safety guidance. Now for task 3, it is looking at physical function as essentially an observational gait assessment. And many elements within this task 3 are related to the TNEDI test, or the performance-oriented mobility assessment gait domains. And that we are, for this part, we start the person in standing. And they start from a standing position, and then we'll walk on a level surface at a self-selected comfortable pace for up to 60 meters. 60 meters was identified from our focus groups as what would be reasonable to look at endurance in walking. And then this requires the person to be doing laps of the 6 meter distance that you set out. And within this is where we have the safety walking distance. We said that the person was unable to walk 5 meters, they score 0. And if they are unable to walk with more than minimal physical assist, then they score 0 and all testing ceases. You don't persist beyond that. But in terms of the observational gait assessment, we're looking at initiation of gait. So are they able to do it no problem, no hesitancy, we're not seeing Parkinsonian-like features, or is there hesitancy or multiple attempts that are required? We look at step length on the right side as well as the left side, and we're looking for symmetry, as well as step height and how well does a person's foot clear the floor, or do they shuffle and they don't have very good floor clearance. Again, if the behavior that we're seeing in the gait assessment is present, then higher marks indicate better function. Path, because we're doing this 6 meter walk distance, we're actually looking at how well does the person control deviations in their path. Do they need to have corrections from us as we're with them, or do they themselves just have a meandering pathway? So if there are no deviations and they form this nice straight pathway, they get full marks. If there's mild deviations, and it's part marks. And if there's marked deviations, then they get 0. So the person's having a hard time actually executing the task. In terms of interaction or equipment, we're looking at a lot of the same things that our healthcare professionals identified. We're wanting to ensure that the feet remain within the base of support. Their feet do not collide with the walker while they're walking. They maintain a nice upright posture. Because we're having, depending on your space that you're actually able to execute this thing in, we need to make sure that their equipment does not collide with any environmental obstacles. Vision problems are very prominent in the early phases of dementia, and they relate to contrast sensitivity as well as depth perception. And so the person's ability to see the world in 3 dimensions becomes compromised, and therefore they have a hard time judging distances and relationships between themselves, the space of the walker, and obstacles or a chair or something in their space. So it's very common that they will collide or could collide with obstacles. And again, do they maintain control of the equipment? So like I said, task 3 is physical function, walking on level surface, and people need to be able to do tasks 1 to 3 as the core task before you proceed on to tasks 4 through 9. Task 4, excuse me, is walking with horizontal head turns. Tasks 4 to 9 are trying to represent more everyday tasks that people will actually engage in while they're out walking around. And with this task 4, we're asking people to walk again at a self-selected walking pace, walking in a straight distance of 6 meters, and they walk around an obstacle and come back, so they're going to walk in a total of 12 meters. But we're asking them to turn their heads side to side. We don't set the timing for their head turns, but we want them to be able to look left and look right and be able to continue to walk. In the physical functions section of the assessment, we are referencing performance of their gait in task 3. We've already done a very detailed gait assessment. So for task 4 and onwards, we're saying, were they able to perform the gait with smoothly and no change in their gait, referenced to task 3. There was minor decrease in the gait speed, so they had to slow down, but it was still a nice smooth path, or there was major decrease in the speed. They staggered, they lost their balance, or they had to stop, being 0 marks. Interaction with equipment, similar items to check for. Feet remain within the base of support for the walker. Feet do not collide with the walker. Person maintains upright posture. Walker does not make contact with any obstacles or anything in their environment. And again, maintains control of the equipment while they're executing the task. So by adding in the horizontal head turns, we've increased the motor complexity of the tasks that they're doing, and we've increased the cognitive demands on the person to be able to do this. And it's to be able to see how close to maximal function is somebody working in task 3 when we're just having them walk and that's it. Whereas once we start to add these extra things, we're seeing how close are they to their maximal capacity. So in task 5 is walking with concurrent cognitive demands. And we are now looking at increasing cognitive demands in the activity, as well as how do people self-prioritize multiple tasks. And again, we're having the person walk the same distance as in the previous one, 6 meters twice. And we're having them perform a simultaneous cognitive task. So with a cognitive task, you need to select a task the person is actually capable of doing, and that the difficulty of the task needs to be individualized to the person, because you want to be able to challenge them close to their level. So you test the person sitting in a chair before you actually have them execute the task. Common tasks that are done in clinical setting, from research that I've done looking at dual task testing among Canadian therapists, is doing counting tasks, 1 being the simplest, 3 is an increased demand, and 7 is an even higher demand. Yes, 7 is hard, it's complex for even people who are cognitively normal, but I've done research projects where I've had people who newly have another diagnosis of dementia, again, more on the mild side of things, are able to do serial subtractions by 7s. On the score sheet, you want to indicate what the cognitive task is that you ask them to perform, because it might change. You might start December 2019, they were doing counting backwards by 3s. December 2020, they were doing by 1s. So you're already seeing, you're able to evaluate a decrease in the person's performance. In instructions that you give to people is do not prioritize any of the tasks. Ask the person to attend and focus on both tasks to do them together. Because what we're also going to be able to look at is how do they prioritize the tasks. If the person is unable to walk and talk at the same time, but they stop talking and keep walking, that's considered a posture first strategy. It's considered an appropriate thing that they prioritize their postural stability over the secondary task. If the person was unable to do both, but they stopped walking and kept talking, then that's considered a posture second strategy, and is considered less effective and is associated with a higher risk for falls. So coming back to the actual assessment form, in the physical function part, we have 4 categories. So if the person is able to do both at the same time without a change in their gait or talking performance and no unsteadiness, they get full marks. If they're able to do both at the same time, but there's a little bit of slowing of either the gait or their talking, and there's a little bit of unsteadiness, but they have control, then it's 2. If they're unable to do both, and in this one, they stop the cognitive task but keep walking, which is the posture first strategy, they get part marks. And if they do the posture second strategy and that they stop walking in order to be able to keep talking at you, then they get 0 marks. The interaction with equipment stays the same. Do the feet remain within base of support? The feet do not collide with the walker. They maintain upright posture. The walker does not make contact with any obstacles in the environment, and they maintain control. So this one is a little bit more complicated in terms of finding the cognitive task that you want to be able to assess for the person. If they can't do counting, then even asking them just to talk, getting them engaged in talking, performing a more a distraction, which again increases their cognitive performance, is also an acceptable method. Task 6 is walking while negotiating obstacles. This is asking the people to do a figure of 8. We place 2 cones 3 meters apart. The person starts in the middle, and then they walk around 1 cone, come back through the center, walk around the second cone, come back, and stop in the middle. Again, in terms of physical performance, we're looking at changes relative to how they did in task 3. So can they do it without changing gait speed or no unsteadiness as they go through that maneuvering? Are they able to do it with slowing? And this is particularly important, is do they collide with the obstacles? This is a specific obstacle thing, again, because of issues related to vision problems. The interaction with equipment, again, it's all the same. Their feet remain within the base of support. Their feet do not collide with the walker. They maintain upright posture, control of the equipment, and the walker does not make contact with the obstacles. Task 7 is walking through an open doorway. And this is related to challenging vision. So are they able to appropriately judge distances for themselves and door frames? So we just need an open door to have people walk through. We want to start the person 3 meters before the doorway and then have them walk through the doorway. If they can walk through the door without any change in gait, and it's a nice smooth gait, then they get full marks. We then look at minor decreases in gait speed, but it's still smooth. 0 marks is if there's a major decrease in gait speed, they stagger, they lose their balance, or they stop. So similar sort of feature that you might see with people who have Parkinsonian features, where walking through doorways or over sills becomes problematic for people. Interaction with equipment, again, looks the same. These are the features that our group said were the most important. Feet remain within the base of support, maintain hand grips, hands on the hand grips, maintain upright posture, and they don't make contact with the door frame. Task 8, again, it's open, walk through, and close the door that opens away from the person. Granted, these are more complex activities, but it could also be the person going, it's how they're able to access their bathroom facilities. So in terms of, there are 8 kind of features of being able to do this that we broke down to, is that when they approach the door, they approach it facing the doorknob, that they reach for the doorknob with their hand closest to the doorknob, and they're able to push open the door without losing balance. They are able to open the door wide enough to get their body and aid through comfortably. They then have both hands on the hand grips of the walker as they walk through the door, and the walker and their body and their aid do not make contact with the door frame or the door. So they were able to judge distances very appropriately. Once they're through the door, they reach to close the door, and they're within easy arm's reach of reaching for the door. They close the door comfortably without it colliding with them or the mobility aid. Again, it's this ability to reference distances appropriately. That they don't need to walk or change their position in reaching for the door and being able to close it, or maneuver their walker with only one hand on it. And again, they're able to keep their feet within the base of support and an upright posture through this entire task, which is a lot more complicated. And this is essentially the highlights of what I've just gone through, is what you are looking for in the assessment itself. Gait speed, same things. We're looking at, can they do this nice and smoothly without any staggering, loss of balance? And at the worst end of it is that there's major decrease in speed, they stagger, they lose their balance, or they just stop. They can't perform the activity. But the tasks that you're looking for in terms of interaction with the equipment are these features specifically. And then the last task is to open, walk through, and close a door that opens towards the person. So kind of the same features, but this time the person will approach the door facing the hinge, and the body is clear of the door path. And that they reach for the doorknob with their hand closest to the door, and they pull it open without losing their balance. That they're able to open the door wide enough to get their body and the aid through the opening without collision. They have both hands on the hand grips of the walker while they walk through the door. Again, they're able to walk through the door without colliding of their body or the aid on the door frame. Now, once they are through, they are able to reach for the door within arm's reach, comfortable arm's reach. To close it, they're able to pull the door closed, and they don't need to make any sort of additional movements of having to walk with one hand on the door or one hand on the walker as they close the door. And again, the person's feet stay within the base of support through the entire activity. These 8 activities or tasks are reflected in what the assessment form looks like. And again, we're looking for, are these activities or behaviors present, yes or no? And then finally, we have to come up with a sum score. So this is the summary page from the assessment. We have each of the 9 tasks. They each have a physical function score and an interaction score. Physical functions, so at the end of this, you will sum the individual scores from each of the tasks to get a physical function score, and the same thing for an interaction with equipment score. Maximum score on physical function is 40. Maximum score on the equipment is 63. Again, higher scores indicate better function. So why go through all of this? Is that it provides a standardized method of assessing physical function as well as safe use of the aid. With standardized language, we have standardized the tasks and what we're looking for to define safety, as well as what are the minimum tasks that are required. Some people may not be able to do all tasks, but then that is part of the evaluation. Again, this is looking at being able to assess people across the full spectrum and across full spectrum of living setting as well, from community to nursing home or long-term care. The other thing with the assessment is that it identifies needs, so identifies either physical performance areas where we can provide strengthening, balance, and gait training program, or do we need to focus in on safety? And because we've provided this hierarchy or specific order of what we are looking for, it makes it much easier to deliver a training program, because these are the things that we want to see. And everybody in the healthcare team knows what those tasks are, knows the order, and therefore can reinforce the training, because we're all asking the same thing of people. And finally, the other thing is that it provides us a means of being able to look at progression of the disease and how it impacts mobility, because we do expect that mobility will decline over time. And by looking at changes over time, that we can also then make modifications within those care plans, whether it's physical function or is it safety, and that treatment is directed where it's needed. If safety is fine, but we're seeing that they're weak, got weak legs, they have problems going from sit to stand or stand to sit, then that becomes the focus. If their safety is good, then we're all right. But again, it just helps to standardize and that everybody is talking the same language. For resources, at the end of this presentation on Loop, there will be PDF copy of the assessment form. There will also be a PDF copy of the user's manual. My lab website you can go to this site, There will be the user's manual, the SUMAC assessment form. There's an English and Spanish version. And we're in the process of creating an online training module using videos to help you assess people and compare that back to consensus evaluations. So please check back on the site for the training module. That's not ready just yet. I would like to thank everybody who's been involved in this, from research assistants to the people at McCormick Dementia Services who worked with us, and their clients who participated in it, as well as funding agencies, including Ontario Neurotrauma Foundation, Alzheimer's Association in the US, and Western Health Sciences Research Foundation. So thank you very much. I'll take questions.
Okay, so thank you so much, Dr. Hunter, for such an informative presentation and for sharing your innovative safe mobility aids checklist with us. We greatly appreciate that. So I'm looking at the Q&A box right now, and I see that we have about 48 questions. So we're going to kind of go through that right now. So participants, if you have any more questions, feel free to put them in the Q&A box, and Dr. Hunter will start, and I will start reviewing them right now. So Dr. Hunter, take it away, and I'm here for support if you need anything.
Great. So one of the questions was asking, is there a height preference for the chair and the sit to stand? For research, it tends to be standardized. And it would be what we would consider the standard height chair. And I can get back to you with the specific details, but we measure it from the floor to the seat height is what we consider standard height. So in terms of how often to assess somebody with a SUMAC, I think at least on a yearly basis, or that's something we still need to figure out, is how quickly do we see progression in function. But it also, I would say, definitely in response to falls or concerns that become noticed, as well as it being part of just a regular routine to see where people are at. So I have a question for the sit to stand is, are they instructed to stand without using the armrest? That is their first. What do we like to see first? And if they can't do it, then they can use their arms. So this is trying to tap into their lower extremity strength and where are their problems, which again should hopefully identify need to engage in exercise program to change that.
And sorry, I'm just seeing a comment in the chat box that just mentioned standard height chair, and I saw 17 inches. Did you want to address that?
Like I said, I'll have to get back because I'm also looking for what we actually did in the study. I will get back to that as a question.
Perfect.
Because it varies, but I can tell you what I used. So one excellent question is, what happens if a client is determined unsafe? Then I think, part of this as well is, so there are two things, actually several things. One is that, that even from part of the research that was done in and around this, is more than half of people who have dementia obtain their mobility aid without having seen a healthcare professional. And nobody told them what to do. It was very common for us to see that the walker was at the wrong height. There were mechanical issues that weren't addressed because nobody told them to service the equipment. So part of this is that people with dementia, even up into the severe, as long as they're still ambulatory, do have the potential to learn new tasks. And we know that from studies looking at learning to perform activities of daily living, that you can train them to perform activities. So this becomes, again, a very standardized process of what it is that you're wanting people to see. So that would be, I would say, the first thing is that if it is unsafe, then that should flag, do we need to actually institute a training program looking at the person being able to complete each of the steps within that, what makes safety. In the interim, then we need to say what sort of oversight or provision of assistance is then required to make sure that person can be ambulatory. And I think we need to be honest about what that means. If it means that somebody needs to be a standby assist, or someone needs to provide queuing, or someone needs to have more assistance, or they just have to stop using the aid, period. We need to be honest enough about that. And then it becomes an entire care decision about then how do we actually end up managing it. So one, like I said, is people can learn, and we need to provide the training program, but we need to have things in place. And sometimes eventually it comes to the point of saying, well, you know, they're not safe. And then there needs to become a bigger question of, do we allow the person still to continue to engage in activity that provides them a improved quality of life, or do we take that away? So that's a bigger issue than this topic, but I think it's also partly about being very truthful about falls and fall risk, and that, again, mobility aids increase risk for falls, and it's up to us to try to minimize what that risk is to the best of our abilities, given the abilities of the person who we're working with. So another question was, do we have a manual? Yes, and that is going to be available on Loop. That will be posted after the lecture, and it goes through each of the tasks. Is there, and like I said, we're working on a training module where you'll be able to view videos of people performing the tasks, and then you can practice evaluating people and compare your scores against what we have as consensus evaluations, but that's in the works. But we do have a training manual. Sorry,
so
just
Dr. Hunter is looking for another one. I'm just going to point out that we're really approaching the final mark. So maybe we have a time for maybe two or more questions, and then we'll wrap up. But just as an FYI, if we didn't get to your answers today, not to worry. Dr. Hunter and I will work to post some responses to these questions within the next coming weeks. So stay tuned for that, and we will get to your questions.
So the next question was looking at what is the best stage of dementia or disease severity. So we validated this, the tool that was developed from our healthcare professionals in people with mild to moderate dementia. But tasks 1 to 3 can be performed by anybody who's ambulatory. If they can't perform tasks 4 through 9 because they cannot follow the instructions, then that is part of the assessment. So then you assign them the appropriate scores that are relevant for that. But everybody should be able to do 1 to 3 if they are ambulatory. But again, if people are needing physical assistance to be able to significant, more than minimal standby assist in even 1 to 3, then you don't do the assessment because you've already identified that this person is not independent and cannot be up and about on their own. They are at a significant increased risk for falls. And I think we need to be comfortable being able to say that.
So Dr. Hunter, maybe we'll wrap up there.
Okay.
And then, as I'm wrapping up, feel free to type in some more questions if you have any. But again, thank you so much for, again, a very, very informative presentation. And thank you to all our participants for joining us today and engaging in this great discussion. So for more information about the Fall Prevention Community of Practice, please visit Loop at fallsloop.com. And the webinar will end shortly, but when it has ended, you'll be redirected to a Zoom and to Zoom and invited to participate in a short evaluation survey. You just have to click the blue continue button on your browser, and then you'll be redirected to complete the survey. And as always, we'd appreciate if you could provide feedback so we can continue to offer high quality webinars such as the one that you just experienced. So that's pretty much it. Thank you all, and we hope that you have a wonderful day and are staying safe considering the times. So see you next time. Thanks, everybody.